their journeys into addiction medicine. So if you can just share what drew you to this specialty.
Oh, sorry. Oh, you're fine. When you're a fourth-year medical student, you get to choose to do electives. And I knew that I was going to go into family medicine, and I wanted to do extra work in psychiatry so that I'd be ready, because that was an area I felt particularly passionate about. And I signed up for an inpatient psych elective, which I thought would be like an inpatient hospital, because that was what I had done as a student. And then when I got there, like physically got there, I realized it was a rehab facility, like in like 4-week residential detox. And they put me in the addiction group, and I did IOP, which is 9 hours a week of counseling with the same group of people. And I loved it. I mean, one, I love the medication because as a physician, it's nice to do things that work, right? Like I want to see results. And with the medication, you get results and you get to see people get better, which is immensely rewarding. But I think also when you're talking about addiction, you talk about so much more than addiction. You have excellent continuity, you see people a lot, you get to know them so well, and you're a part of their lives. And often, prior to interfacing with you, people can have really difficult lives. Those things will come up in their discussions with you, and I think that in addiction particularly, I felt like that I was able to see and know and treat the whole person.
Yeah, absolutely. I echo a lot of that. I think we're family physicians at heart, so we are trained to treat our community. And so I think when I was in training, I just saw the need in the community. And we think about other chronic diseases that we treat, like hypertension, diabetes. Addiction is as prevalent, if not more prevalent, than all of those combined in some cases. And so when you think about training to treat a community, you need to respond to the needs, and addiction was a significant need. So for me, it really started an interest in training where I was just seeing the burden of untreated addiction really affecting my patients across the board. I was also really fortunate to have some wonderful mentors, particularly Dr. Suzanne Krasovich and Dr. Maureen Langeway, who really built this clinic from the ground up. I had the privilege of talking about it today, but they were really the founders. And so even as a resident, not yet out in practice, they invited me to collaborate with them. So it was really a little bit of serendipity of seeing the need and also being invited to participate in the project. And again, echoing what Dr. Tamar said, just there's very little else we do in medicine that helps people so quickly, and it's just nice to actually see those lives restored from such a simple intervention. And then from a personal use, my family was affected by substance use disorder, and my mom died from alcohol use disorder complications. So I am very much tied to both professionally and personally seeing some change in this space. So I think those two things together are what motivate me to try in my little corner of the world to make a bit of a difference.
Thank you. Yes. So we talked a lot about systemic barriers to treatment, such as lack of access to healthcare services, transportation, childcare, financial constraints, et cetera, et cetera, et cetera. How do you navigate that, and what can we do to change some of the barriers in our system to make sure that people who need support are actually getting it?
So as you guys know, I work for an organization of methadone clinics, right? If you are unstable in treatment as a patient in Wisconsin, you're coming to our clinics to dose every single day. In other states, clinics are closed on Sundays. They're allowed to do that by state law, or they can be closed on holidays. But in Wisconsin, since 2020, the clinics have to be open 365 days a year. So if I'm thinking about the barrier that most impacts my clients, I'm thinking about transportation, right? So all CMS clinics are typically on bus lines that go both ways. We have to think a lot about parking because we have patients that are coming every single day, and probably 50% of our patients or something like that take public transport. So reliable transportation for people who are like on Medicaid transportation or VAO, that's a huge, huge issue for us, right? Like I still remember there was a snowstorm, I think in March of 2023. It was a big day. It was a very traumatic day for me. But so a lot of our patients couldn't come in. Their VAO drivers simply wouldn't bring them, right, to get medication. And I bring that up just because, again, like imagine, I'll put it out there. I had a dream once. It was when I was in addiction fellowship training. I woke up, or my dream in fellowship was that, for whatever reason, it's a dream, right? It doesn't have to make sense. I have an opioid use disorder. I'm on methadone. And I thought to myself, oh my God, in the dream, I'm going to have to go to the methadone clinic every day. I'm going to have to go to the clinic every day for months before I can work up to having like a take home, before I can work up to having a week or 2 weeks of take-homes. And I'm not a morning person, right? Like, I like many people are not. So in the dream, I was just absolutely crushed. Like, I was like, oh my God, I'm gonna have to reconfigure my entire life to make this work. And then I woke up and I was enormously relieved, of course, but I still think about how crushed I was in that dream when I'm thinking about our patients, when I'm telling them on day one that we're gonna be seeing them 365 days a year. All that, I think, to press upon you the importance of having reliable transport for people who are relying on their insurance for transport.
Thank you.
Yeah, absolutely. I would echo that. My pie in the sky dream would be to Xerox Colleen Ellen 1,000 million times and just have her run around everywhere. But really, it's all of those not awesomely reimbursed things, and it's the soft skills like connecting with people and home visits and like seeing their baby with them and the mom. It's all of those things. So transportation, absolutely. In my world, perinatally, childcare is a huge issue. Turns out you can't take your 2-year-old to your ultrasound. So we wonder why people don't show up to their growth scans. It's not because they want to hurt their baby, right? That's the assumption that people make, or they don't care. No, it's because who else is going to watch their 2-year-old, right, for your 25-minute long growth scan, right? Huge barrier. And despite, I've made a lot of phone calls about it, and sometimes we can bend over backwards, and literally I've had labor and delivery nurses who had a minute stand there and hold that kid's hand in the waiting room. But those are the actual practical barriers we face, particularly with families. At Bethany Recovery Center, we're privileged to be able to allow babies, but we get women all over the state. I just had one not too long ago who transferred her care 10 days before her delivery because where she was at wouldn't allow her to have her neonate. So she was facing the decision between staying in treatment without her infant or transferring 4 hours away from home to have a delivery with a doctor she's never met before. And those are the practical barriers that people face. So I think in terms of thinking about reducing barriers to treatment, it's peeling away those extra layers, those extra training requirements, those extra regulatory issues that prevent treatment. You can kill yourself a lot easier with insulin or Coumadin than you can with buprenorphine. So it makes no sense to me why we have all these other extra layers to getting treatment that we don't have for other equally or more dangerous substances. So I could go on and on.
No, I appreciate that. I asked the question because I want us, the Heroin Task Force, to continue to think about how we can change the system. We keep talking about different things where we can dig a little bit deeper, so that's why thank you for bringing some of those things up. The other thing that you talked a lot about was stigma, and we have a stigma reduction team for that reason, because stigma is a big deal. What steps can be taken to reduce the stigma of surrounding addiction and encouraging people to seek treatment? Either one of you want to start?
No, go ahead. Okay.
I think that Dr. Fox did a really good job alluding to this. When I'm seeing patients, because this happens all the time, right? Somebody comes in, they start on methadone, they're stable, the dose doesn't matter. Maybe it's been 4 weeks, they come in and they're like, I want to taper off, right? And then you're like, why? And after some hemming and hawing and usually some walking around the main issue, it'll come out like, my mom doesn't think this is real recovery, right? Or like the father of my baby thinks that I'm poisoning our child, right? And I need to come off. Or my OB makes me feel bad by commenting on the dose of my medication at my visits, and I don't want anyone to think that I'm harming my child, so I'm going to taper off. So when I'm thinking about stigma and how to reduce it, I'm typically thinking about conversations, right? Because in my experience as a medical provider, nothing works as well as a family meeting. Nothing works as well as getting everybody in the room and having a discussion around, okay, what are our ideas around medication? Are they based in truth, right? Where do these ideas come from? And what are our goals, right? Because I think when we're talking to a family, generally everybody can anchor to the fact that we all want our loved one to be safe, that we all want our loved one to live on and have a safe pregnancy and a happy life, and the medication gets people there, right? It's just often that family members, community members are not aware of that.
Yeah, I would echo it. It's really educating people, providers, all of the above on the difference between dependence and addiction. I mean, that's a huge part of what I do. And so I hear that all the time in terms of like, well, my recovery is asterisk less than because I'm using a medication. And so multiple times a week in my clinic, I will literally pull up the criteria for opioid use disorder and look at it with my patients and say, tell me what criteria you still meet, right? Regardless, like there's nothing on this chart that even says, oh, but if you're on medications, subtract 3 points. It doesn't work that way. So I often see the light bulb go off in my patient's head when we talk about that, but then it's getting it to mom and father of the baby and the rest of the community to help people understand. So that's part of it is just education on the medications, understanding the neurobiology of addiction as a structural brain disease. No one shames people with type 1 diabetes for taking insulin. They literally need it because their pancreas doesn't work. Well, you need medications because your brain doesn't work right now. So I really try to think of it as a chronic disease like any other disease I treat in my family medicine clinic. And then as we're working on stigma, I think increasing access helps with that. When you walk into my office, no one knows why you're there. It's a primary care clinic. You might be there for your blood pressure checkup, your physical, your prenatal, or your buprenorphine, all of the above. And I think that really helps increasing access into the community to further not only improve access, but also reduce that stigma, because you can sit in my waiting room and no one has any idea.
So I'm going to ask you, we talked a little bit about this as we were prepping, Dr. Fox. I asked you a question. If you could wave a magic wand, what could be done to shift the narrative for pregnant patients from judging a pregnant woman in recovery to better understanding that these patients are going through that chronic medical condition? So rather than just the patient, but it's kind of that surrounding the views of others, if you will.
Yeah, that's a tricky question. I might not have a single articulate answer, but I think one thing is understanding and respecting how hard it is to present for treatment, particularly methadone. I mean, as Dr. Tamar was saying, this is literally, I think about my first pregnancy with my kiddo and how sick I was and nauseous every day and I barely could get out of bed, like dragging my butt to the methadone clinic every single day. Like, that's crazy. So I think just having a deep degree of respect for how much courage it takes to seek treatment and how hard treatment is. Like, it's not only the medication visits, it's extra ultrasounds, it's all of this stuff. And all of my patients truly are committed to a healthy pregnancy. Like, we all want that. And so I think there's just this stigma out there that these are bad moms or bad people who don't care, who are intentionally harming their patient. And so to answer your question, I wish I could change the question from like what kind of mom does this to their baby to what kind of disease does this to a dyad, to a person. Like, how horrible of a disease must this be for these things to happen versus like how horrible of a mother or a person. So
wow, that's a huge shift in language. I love that. Do you want to add anything to that?
I think Dr.
That's an amazing shift in the language. Thank you. Dr. Tamar, we talked about correctional MOUD and the correctional facilities. I think I want to know a little bit more about what we can do to help change the culture around substance use in correctional facilities. And I know we have some policymakers in the room. What else can we be doing to support them to make changes that might make it better and easier for people to get what they need in the correctional facilities?
I have been spending a lot of time on this soapbox recently, and I have been to multiple correctional conferences within the last year, and as a non-corrections person, it surprised me to learn that the point of the corrections is to be rehabilitative. That was not something that I was familiar with prior to going. It's not, I don't know, I'm a doctor, nobody tells you stuff like that. And I guess because I have toured multiple correctional facilities now, and I think that at many of them, there's not a lot of things that I would point at and say, that's rehabilitative. But I think the outcomes speak for themselves, right? And I'll tell you, I know I've told you a lot of stories today, but I'll tell you one more. I was recently on a meeting with a correctional team in a different state entirely, not Wisconsin. And we were talking about the importance of medication, right? That we were talking with other medical providers, and the issue we were having is that the other medical providers would look for any reason to wean our patients off medication, right? Like any abnormal lab, any side effects. They'd be like, well, it's the methadone, it's the buprenorphine, you've got to wean it. So I had to get involved to be like, please let my medical providers do their job, right? Like, all the things that you're saying are attributed to this medication, like, this is not true. Let's have an evidence-based discussion. And at the end of it, one of the providers said, I just feel like if we're giving people these medications and 3 more meals a day, then what's the point of jail? Yeah, that's what I said too. Pregnant silence. But I think what I most want to impress is that for a very long time in this country, right, and I think probably worldwide, we've treated these medications as different, right? You've had to do all these extra things to get these medications because they're somehow other, right? This is not aspirin, this is not metformin, it's not lisinopril. You've got to jump through hoops to earn these. And it should not be like that. Because whether our goal is less taxpayer money on corrections, whether our goal is enhanced, improved outcomes for people that are in our care, people in a correctional facility, MOUD does all of it, right? And I think that in terms of like, if we're trying to change the culture, as I think Dr. Fox and I have said a lot about this today, a huge part of changing that culture is just changing the misinformation. Because when I'm on discussions with correctional facilities providers, I think we're all on board. We all want the same stuff. It's just a matter of wading through erroneous ideas, wading through ideas like, well, the medication makes people sedated or the medication makes people high, right? It doesn't do any of those things. It does all these positive things. And if our goal is to rehabilitate people, then I think this is a huge part of how we get there.
Can I
Yeah,
add one
yeah,
thing?
absolutely.
I
please.
have to take advantage of the people in the room. So if there's one thing I could ask for the policymakers is, I need your help with better discharge planning from correctional settings. So this is my life at Bethany. One of our floors is entirely dedicated, I can see Amanda laughing because she knows where I'm going with this, is dedicated to Department of Corrections clients. And the average phone call I get on Friday afternoon is, so-and-so's discharging from Dale. They refuse to give us anything more than 3 days of medications. They are pregnant, right? So they can't go through withdrawal because that could cause serious harm. Can you get them in on Monday morning? Well, my clinic's triple booked. My team is awesome. We will figure it out, but creates total chaos. I've had to, I don't turn people away, but I've had someone sit in jail for 11 extra days because I could not get them an appointment to get their medications transferred sooner. I've had parole officers sit at Bethany for hours figuring out a medication plan because we get so much resistance with prescribing more than 3 days of a necessary life-saving medication. So please help. I would love a month. 2 weeks would be great, right? But truly, all jokes aside, we wonder why the incidence of overdose is so high after jail, even if you're not in my setting, which is a highly supervised, highly supportive residential treatment facility. What treatment center, I don't know what your intake rate is, but what primary care office can see you in 3 days for a new complex chronic condition? It's not possible for most people. And then throw in rural setting, right? You're kind of screwed. So if there's one thing I could change correctionally, it would be more foresight into discharge planning, particularly with medication supply.
Excellent, thank you. Thanks so much. The last question, and this is for you all here, how might we be able to, the Heroin Task Force, be able to help support your work? You gave us some specifics in terms of discharge planning. That's something that we might be able to advocate for. But what else can we do as a collective body to help support your work?
You guys are in such a unique, exciting position because the recommendations you make will dictate where the money we have to put at this problem goes, right? Policymakers are going to be looking at what you think influences overdoses, and that is what they are going to look at, going to act upon. If there was anything, I think, if I could ask for one thing that often comes up. So, as Dr. Fox said, we should not withhold the medication to make people seek behavioral health, basically because it's totally unethical to withhold life-saving medication. But there are so many instances in which people are interested in behavioral health. Like they want to go to residential treatment, right? Or maybe they want to go into some sort of sober living and they're unable to do so because they cannot continue on their medications while they're there. So I could tell you I could count on one hand the amount of residential treatment programs that patients could go to in this area if they want to stay on their medication. And we have a lot of residential treatment programs. We just don't have a lot that accept people. So, and that includes people that are on, pregnant people that are on medications too. So if I could have one ask, it would be directing the treatment programs in our community, hey, we love treatment, we want patients who want this to have it, and we want them to stay on their medication because that is what's most ethical and that is what's most evidence-based.
Thank you.
Well, I think I made my big ask, but that's mostly to make my life easier. Yeah, absolutely. I think it's continuing to reduce the burdens and the regulatory steps to get these medications. So we've made huge progress, reducing the, I made that joke about how insulin and Coumadin can kill someone easier than buprenorphine, yet you have to take 8 to 24 hours of training to prescribe buprenorphine, but an intern one day out of medical school can prescribe all the Coumadin they want. So we've made really big strides, but continuing to work on creative thinking about how can we make this easier and easier and easier, both in terms of the patient-facing side and honestly the provider-facing side. The less training I have to do, the less licensing I have to keep up, the more people are going to do this. And then continuing to support training, that's putting on my hat as a teacher. We have lost funding for primary care spots over the years, and that's less and less people who are out there in the community, aware of what the community needs to treat these patients. So efforts to reducing barriers, working with the correctional system, and continuing to support addiction training for providers, I think, is key.
Thank you.
Thank you so much. Just a quick round of applause for our